Some factors that can decrease DLCO, like I said, anemia, carboxyhemoglobin, pulmonary embolism. If you don't have blood flow, you're not going to have gas exchange. Diffuse pulmonary emphysema, or pulmonary fibrosis, pulmonary emphysema. There are some factors that can increase DLCO. Polycythemia. If you remember, polycythemia is an increase in hemoglobin. You've got more hemoglobin, more is going to want to go across. Remember that hemoglobin loves carbon monoxide. Okay? So if you've got more hemoglobin, it's going to act like more magnets and suck it across. Obviously, exercise, you have a greater demand. You're going to have an increase in DLCO. If you can actually measure this, some of your advanced testing during exercise. And lastly, congestive heart failure. Now, I'm not going to explain to you here why congestive heart failure would increase the DLCO. I want you to think about that. I want you to think about what about congestive heart failure would cause you to have an increase in DLCO. And then we'll talk about it in class and see how right you are. Okay, let's look at interpreting the entire PFT report. The FEV1-FVC ratio is a good place to start because bottom line is if your FVC is one value and your FEV1 is less than 70% of that value, you have some obstructive properties going on. Okay, FEV1 is how much gets out in the first second. If the total lung capacity is less than 80% of predicted and the FEV1-FVC is normal, you have a restrictive lung disease. Keep in mind, the FEV1 to FVC is a ratio of what I blew out, how much did I get out in a second. We're not saying the FVC is normal, we're saying the relationship between the FEV1 and the FVC is normal. Okay? If your DLCO is less than 80% of normal, a diffusion defect is present. You could have a reduction in surface area participating in gas exchange. That would be your emphysema. You could have a thickening of the AC membrane. That would be pulmonary fibrosis. Now, this is just kind of a nice little interpretation slide that I put on here that just kind of shows you, okay, if I have an obstruction, what would I expect? If I have a restriction, what would I expect? Common sense, you don't really need this. Common sense is going to tell you the basics. If I have a normal FVC, but I have a reduced FEV1, I have an obstructive pattern. If I have a reduced FVC, but I have a normal FEV1, that's more indicative to a restrictive pattern. When I do my lung volumes, if I have an increase in RV, it's going to increase my TLC, which means I'm probably going to have some air trapping going on. If I have a reduced total lung capacity, everything is going to be reduced, which would tell me I have something restrictive going on. When we talk about flows, we're looking at obstructive. When we talk about purely volumes, we're looking at restrictive. When we're talking about the relationship between flow, volume, and time, that can help us determine, is it an obstructive problem or is it a restrictive problem? Okay, DLCO, if it's reduced, gas exchange is not occurring. The AC membrane is wide, you have decreased surface area, you don't have adequate hemoglobin, you have carbon monoxide poisoning, carboxyhemoglobin going on. If it's increased, you have congestive heart failure, you have polycythemia, etc. Or you're exercising. Don't make PFTs be harder than they have to be. Don't make the interpretation of them be harder than they have to be. I put a PFT in front of you. It can have gazillions of different little values, but we have to pick out those that mean the most to us. We cannot sit here and try to interpret every little volume and every little flow. We'll get so lost in the process that we won't understand what's going on. We look at on spirometry, FEV1, FVC, FEF 2575, maybe FEF 200, 1200, and your peak flows. Boom. Lung volumes, we're going to look at RV, we're going to look at TLC, we're going to look at all the different compartments. In DLCO, we're looking at something that's preventing us from participating in gas exchange, going across the AC membrane for some reason. If you remember that and don't get caught up in all the little nuances, you'll be fine. Okay? So that pretty much concludes this section. When it comes to interpretation of PFTs, again, I've said each time we're going to be doing that in class because it's just so much easier than trying to do it in this way. So we'll be putting some up on PowerPoint, and then you guys will also be assigned some that you have to interpret. You'll have to go through each one and figure out, is it normal, is it abnormal, is it obstructive, is it restrictive, what's going on. And then perhaps based on some history, you might be able to determine what's going on. This section has 4 case studies that you'll need to complete. That gives you just a little bit of information and some values, and you need to interpret those. Okay, take those seriously because those are the basics that help you. What they tell you and the values they give you, and you'll find that they won't give a table like this. They're going to give you the basics that you really need to know. They're going to give you FEV1, FVC, maybe the 25-75, the FEV1 to FVC ratio. Maybe they'll give you lung volumes. Maybe they'll give you Dlco. They're not going to get caught up in all of the different pieces. Okay, so that concludes this section. Coming up in the next section will be some special studies that we can do. We're not going to spend a lot of time here. Your average PFT lab won't be doing these, but some of your more advanced ones, such as going to Via Christi, they can do some of these things. And then we're also going to talk about quality assurance of a PFT lab. Just like blood gases, because we're doing values, we have to have some quality assurance that takes place that we can show that we are making sure that our spirometers are correct. So, thanks again.